You've got it. Fantastic. Thanks very much. I'm sorry for the delay. Look, it's lovely to hear the other presenters, and it's exciting to see the work that's being done through the NCNED as well as other people. So with acknowledgement to country as well as my contributors and colleagues in this space, I'd love to talk about ME and what's traditionally been known as ME-CFS. My goals or targets that I've asked me to discuss is what can we do about this in primary care? What is Naltrexone? And the point is that it's off-label, but currently on trend and on point. And non-allergic rhinitis, what is it? And in fact, it's a common and unrecognised comorbidity that is really easy to treat and can improve people's quality of life. So it's a really easy win. So I'd like both patients and clinicians to be aware of this, and also why it may occur as well. I won't spend too long. Stanley's done a lovely introduction, just saying initially they thought that my encephalopathy was a infectious process. They recognised outbreaks and diseases. There's been various definitions that have improved the specificity of diagnosis. I've actually, which involved the Canadian consensus, the International Consensus, Institute of Medicine, now the NICE guidelines, which reflect the importance of a biosocial model, highlight the importance of pacing and shared decision making, so the patients being involved in their care. I like to think of, in a primal model, why our body may do things to protect ourselves. And many patients with ME-CFS may feel brain fog and like the deer in the headlights. They may feel like curling up like an armadillo, or the body may protect itself to go in to a hibernation in response to a threat. And this is what our bodies do in response to threat. But when we're in threat, we actually become on guard. So we feel agitated, we're over perceiving information. So our body has a lot of threat reception networks. And as it's turned out, we have dysfunction of our threat receptors, as has been discussed by Stanley and Etienne. And the processing of that, as Kieran has discussed, in our mood centers, our hippocampus, but there's also engagement of our autonomic nervous system that goes through what appears to be a swollen brainstem. So it's our body is trying to do the right thing, but it amplifies it and gets it wrong. The Canadian consensus I find really easy to use, but hence we do have to, as San's mentioned, we have to talk about post-exertional malaise being a predominant feeling. It has to be present for more than 6 months. We need to make sure that we haven't got an infectious cause of this acutely. And as has been mentioned several times, COVID has significant overlap as well. And it has to be individualized. It's not, this is precision medicine, and we have to treat patients as individuals, or not a cookie cutter medicine. As part of the additional features and definitions of chronic fatigue, they talk about irritable bowel that's been mentioned, brain fog that's been mentioned several times, hypersensitivities to foods, odors, and chemicals. So when there's a threat, our body is on guard at centers that places may receive information, such as the eyes, the nose, the ears. It can be sense of smell, but in fact it's chemical perception rather than odors, and olfactory reception. It's chemoreception that involves a trigeminal nerve that creates a dull feeling across the head, which is called non-allergic rhinitis, that you'll look like you've got allergic rhinitis, but you in fact don't have that as well. So diagnostic tests, and feel free to cut and paste this page, but also there is a hard copy of it present as well. ME-CFS is currently a diagnosis of exclusion, and as part of the workup, we want patients to have a full blood picture, see the rate of inflammation, ESR, and you could do a C-reactive protein as well. Thyroid function test, look to see electrolytes. Something like Addison's disease may present as a fatigue-like illness. Renal function test, renal failure can also present with fatigue. Liver function, fasting glucose, urinalysis. If you've got particular joint disease and pain in the joints, look for autoimmune diseases. Screening for common infections, look for IgG, which tells you have had this in the past, but IgM occurs acutely with acute infections for the glandular fever syndromes. In Queensland, if around livestock, think of Q fever, human herpes viruses 6 and 7, COVID, and in appropriate areas, Lyme disease. And I don't want to get into the discussion of Lyme disease in Australia. It's very controversial. But there's certainly areas that Lyme disease is well recognised overseas, and we have patients who've lived in those areas and have Lyme disease. Hormonal assays, again, if we think that's a factor, sleep studies if suspected, and consider vitamin nutritional analysis. We have so many nutritional deficiencies intrinsic in our Australian diet that we could improve, and it certainly doesn't help the load, because if there's nutritional deficiencies to start with. And as a patient who's got fatigue, there's the pre-stored meals, so you're going to get low in vitamin C, you're not going outside, and only 10% of our nutrition for vitamin D, only 10% comes via nutrition. So safe, sensible sunshine is the way that we should be getting it. So it's easy to become deficient with processed meals, which are easy to heat, easy to make. They have a lot less of the proteins, amino acids, the lipids, magnesium, and micronutrients that real food has. So your ongoing patients is a different assessment compared to your patient who you're seeing for the first time. Think of lying and standing blood pressure. Again, it's been mentioned about the orthostatic intolerance and that control, which is regulated through the brainstem, as Kieran's mentioned. Looking at the prospects of a diagnostic tool, the group at the NCNED, basically back in 2014, identified there's a problem with the cell membranes and flux through the cell membranes that look like it's regulated via TRPM3, but there's other TRPs involved as well. We have TRPA1, and Stanley's PhD is on TRPM7. So these are ion channels that seem to regulate influx of cations. These are positively charged ions that affect energy levels within the cell. So we're thinking of mitochondria, but we're also thinking of the cell membrane and the way that it behaves in its excitable state. A group in Stanford have also identified cell membrane characteristics and excitations as possibly being a biomarker, and we hope that we can provide in the future a better tools for identifying patients, as well as defining response to treatment as a result of all the excellent work that's been done by the group at NCNED. Range of therapies vary quite a lot, and it has just been mentioned. Talk therapy, getting patients feeling not so hopeless, that having optimism. The brain is a very, very powerful thing. We do underestimate that in medicine. If appropriate, graded exercise, but that's not for everybody. In COVID, I think it's reported that only 1% of patients improve with graded exercise, 75% deteriorate. And again, with ME, it doesn't work for everybody. There's the occasional patient that it hurts. So the focus is more on pacing, being kind to your body, listening to your body. There are no FDA or TGA approved drugs for ME, and what we do use is used off-label, and it's important to have that discussion with the patients as well. Nutrition, it's really important to get that balance, as are our foundations of health that I'll talk about. And we have a range of expertise in managing the patient. It's not a channel where somebody, here's your illness, here's your drug, go and get better. There needs a lot of support. In fact, there's specialised coaching that exists for patients with ME/CFS, and actually having a tribe is important. So the patient support groups, peer-to-peer support is very important as well, as long as people have positive stories and focus on that. It's very easy to focus on negatives and spiral down. So when our bodies is under threat with an illness, whatever it be, we can become more on guard to odours and sensitivity, what's in the air, what's in the noise. We're more sensitive to infection, and colds and flus can wipe people out with COVID. Foods that we normally tolerated, as Dan's mentioned, we can start reacting to because the body is sensing danger. Foreign materials, and we see people responding more to implants and breast implants and dental implants and pelvic implants when their body's more on guard as well. If you're having surgery with ME/CF, it's another injury to the body. There's and the body has to be prepared in mind for that as well, and know that it's not a danger that they have to shut down and withdraw from life as well. And we see patients having surgery and they regress. So thinking about the body and telling the body it's important is very important. There are a lot of chemicals that we have, forever chemicals. Again, that could be an entire talk on itself. And our microbiome is related to gut-brain function, gut-lung function, gut-skin function, and eating healthy is important for that, but also state of mind is important. If we're stressed, we actually can change our gut microbiome. Taking medicines can change our microbiome as well. Balancing that yin and yang is the important for getting quality, refreshing sleep. So it is important to try and have, where possible, sleeping and waking hours. It is important to have whatever movement that you can, and your posture is important as well. If you're hunched around, on your phone all day, your body's going to say you're in danger. If it's important to get good nutrition, as I've mentioned, eat the rainbow. Having a sense of purpose is important, and that is often lost during illness. But seeing that purpose, knowing what you're good at, utilising it in small parts is important in going forward. And that sense of belonging, you lose your work tribe if you've got severe ME/CFS, but you can find new tribes. And human loneliness is such an important factor. Loneliness is the new smoking, and has got serious detrimental impacts on health outside the impact that it has in ME/CFS. Low-dose naltrexone is something that can be useful. It's not the messiah for everybody, but we, the team with Etienne and Natalie and others at along with Sonia at the NCNED, have been looking at this in both ME/CFS and long COVID. It is off, if doctors are using it, it's important to document that it's off-label and discuss it with the patient. It doesn't work for everybody, and it's important to manage expectations. In my hands, I find about 80–85% of patients do experience benefit, and the cost can be $150 to $200 to try and use a compounded medicine. And you'll know the benefit usually in the 6 to 8 weeks. And there is that fear when you're actually unwell, there's this fear of missing out, or FOMO. So a lot of people will try everything. It's important, if something doesn't work, have timelines, walk away if it doesn't. And the main side effects that we do get with low-dose naltrexone is tiredness, but rarely lethargy. And also there is vivid dreams that can occur with that as well. The NCNEDs found TRPM3 not to be functioning properly. There is there's a type of TRPM3, and there's many various types of that, and one particular form seems to be a dummy type of form that people with both long COVID and ME/CFS have, and it's not functioning, and therefore it's a regulatory ME/CFS. So think of it as dysfunctional middle management. It's just not working well, and that seems to be influenced by opioid receptors as well, and it seems to alter the flow of calcium and other cations into the cell, which is involved in activation, the release of neuropeptides, and normal cellular function. So as Etienne's mentioned as well, opioids inhibit TRPM3 and unshackles that control of TRPM3 on regulating other ion channels, which I really don't need to go on too much more, but it actually works beyond that as well. There's a danger molecule from injured tissue called high molecular group box 1, as well as a danger receptor called TOL4. And naltrexone actually seems to interfere with the excitation of the high molecular group box 1 protein, as well as TOL4. It's also, there's a process of cell death and cellular inflammation called pyroptosis, so fire-induced cell death, and the NLRP3 pathway is an important inflammatory pathway that naltrexone also works at. So there's several methods that naltrexone looks to be important, but for those people involved in dosing, I was, when I first was using this 5 or 6 years ago, I was thinking, oh, this is a drug that we use for patients who've got alcohol abuse, or it's a drug that we use for acute treatment of opium overdose or heroin overdose. So I was thinking, just choosing it out of context, but with the depth of research that we have, it's been used in a wide range of conditions. And it's important to start at a low dose and we build it up. I tend to start at 1.5 milligrams and every fortnight step it up to 4.5 milligrams. I give it at night so that people get used to it, and if they get tired, it's not an issue. But 15% of patients on that are sensitive to the 1.5 starting dose. So we can start at lower. So some people will start at 0.5. If you're really, really sensitive, just dilute the 1.5 milligram capsules down. You can start at 0.1 milligram, but very low dose naltrexone is in the range of 0.1 to 1.5 milligrams, and very, very low dose is 0.05 milligrams. I'll just finish this up now with a brief discussion of non-allergic rhinitis. And this is from a colleague, Jonathan Bernstein, who is in Cincinnati, and he created the Cincinnati Irritant Index. So a lot of irritant triggers that many of our patients with non-allergic rhinitis and ME/CFS will be aware of. In fact, this is, I was aware of there being a dysfunction of TRP channels in patients with non-allergic rhinitis when we first had our discussions with Sonia back in 2014, which led us to look at TRP receptors as being potential mechanisms in patients with ME. So these patients are over-detect threats of chemicals and will get headaches and feel foggy in the presence of strong smells, cold, dry air, solvents, smoke, bleaches. There's a range of them. Anybody who's seen me probably know I can rattle off 40 different triggers as well. But they seem to hit a receptor called TRPV1 or TRPA1, which does get regulated somewhat by the TRPM3 function. And in patients, when they do biopsies, there's more of these receptors on sensory nerves. So patients are detecting danger. And in mice where they've actually knocked out this gene, they're actually not anxious at all. They feel very calm and relaxed. So the patients with this are over-detecting threat, over-detecting danger, and it goes through this down to the brainstem, to the area that Kieran was talking about, and is involved in autonomic functions. There's trigeminovagal reflexes. So you smell something, your heart goes fast and your stomach feels sick. Just think of being around a malodorous smell, or being around smoke and sick in your stomach and getting a headache. That's up to 1,000 times more intense in patients with non-allergic rhinitis. So with an injury, our bodies are on guard. As I've mentioned, there's overexpression of TRPV1 in the trigeminal nerves. We have increased numbers of these receptors, and our airways move 12,000 litres of air a day and filled up to 100 millimolecules per breath that we take. And there is a strong association with dysautonomia when our body's autonomic nervous system is on guard, it's dysfunctional, and so it gets guard at one of the major points of entry of threat into the body, which is the inhaled threats, which is our nasal airways. There's the TRP receptors, as Etienne has mentioned, are gateways which allow flux into the body, but there's also natural compounds that influence these receptors. TRPV1, as I've mentioned, is a hot burning pain receptor for chili. TRPA1 is a menthol receptor, as is TRPM8. M5 is sugar, and there's MSG as well. Allicin, which is in garlic that makes us cry, hits TRPA1 and V1. So these are very important because they are present on the trigeminal nerves that are detecting danger. And as I've mentioned, it's chemical reception, not the smells. And it's up to 1,000 times stronger in patients who've got this condition, the detection of chemicals. And they'll pick up chemicals such as the smell of bacteria, or a smell of smoke, or the smell of mold, where from thiols and lactones chemicals there when other people can't smell them and will feel unwell from them. So patients can get anxious because nobody else can pick up these chemicals, and they think it's them and phantom smells, but it's not. They're just more evolved. And from an evolution point of view, it's important to be able to detect danger if your body's injured. So these people evolutionary who were super smellers, who tell the tribe foods are okay to eat, or it's okay to camp in this environment, or not if there's mold there that would make other people sick who couldn't pick that up. So these ion channels do cause vasodilation when stimulated, so it affects the blood flow to the meninges and can be associated with horrible headaches as well. and blocking TRPA1 does seem to improve headache control as well. So the treatment, as promised, is to avoid the triggers and identify them, and I discuss those with my patients. I love an air purifier, and my interest in them has increased post-COVID, and also from the feedback from our patients who have them. Pharmacological treatment, there's a range of pharmacological treatments, and there's this review that is in print in the Journal of Allergy and Clinical Immunology. It went live on the 11th of March. It should be in press in the next month or two, but it's available ahead of print if people want to see that. I tend to use a medication called olopatadine, which I used to have access to that from 2009. It became available in Australia under the prescription of Ryaltris. We can use capsaicin, and repeated dose of capsaicin can actually burn out those nerve receptors. And again, I'll be doing trials with those, leading a global study later this year and early next year. And if it's really refractory, we can chop the nerves so they don't do the over-detection, but that again is a threat in itself. So in reflection, what can we do in primary care? I hope that I've covered at least a foot in the door, recognising the condition. As Stanley pointed, don't gaslight patients. If you don't know, it's important to say that you don't know. Naltrexone is used off-label, but you've got a International Centre of Excellence within CNED having many published papers saying there is a strong biological rationale, and in fact by doing nothing you actually can be doing harm. So feel that you've got the safety and backup of experts who are already using this. Just because it's in trials now doesn't mean that it should not be used until we have it and it becomes part of protocols, which can take 10 years to develop. And non-allergic rhinitis, the common and unrecognised comorbidity that really is easier to treat and can improve people's quality of life significantly if we address it. So thank you.